all, I just want to thank the organizers for giving me this opportunity to present. I'm really excited to be part of this day. I think it's a really important initiative to talk about quality improvement in OB imaging, which is very close to my heart. So I'm going to spend the first part of my presentation talking about education, quality improvement, assurance, and obstetrical ultrasound. And then the second half will be sort of reviewing common thoracic pathology. So we'll just go ahead and get started here. So I have no disclosures. Over the course of the next 20 minutes or so, I'd like to sort of focus on the importance of quality improvement and quality assurance in obstetrical ultrasound, as you're all well aware of, and that's probably what's bringing you here on a Saturday morning. We want to talk a little bit about ultrasound education, how to assess competency. I'll share a little bit about my own experience working as an ultrasound international trainer for ISWAG Outreach. And then I'll focus a little bit more on improving quality of OB ultrasound in our own units. How can we implement standards effectively? What the role of accreditation is, and quality assurance and performance indicators that we should probably strive towards nationally and locally to really monitor our own performance and improve how we're doing. So quality improvement and quality assurance in prenatal diagnosis, why is it important? So we all know why it's important. I mean, this was a recent story in the media. We're looking at Jimmy Kimmel's son who had diagnosis of tetralogy fallot that was missed prenatally and required cardiac surgery sort of emergently and unexpectedly postnatally. And this story, of course, raised a lot of concerns and gained a lot of media attention about our congenital heart disease detection rates prenatally. And a lot of attention has been in this area, looking at areas to improve, because in fact, our congenital heart screening is not as good as we would like it to be. And this is a bit of an older study looking at the performance of congenital heart disease detection rates in California. And what they found was only about 30% of critical cardiac lesions were being detected, despite almost universal ultrasound in this series. What they found was that it sort of depended on the type of congenital heart lesion. So not surprisingly, things like total anomalous pulmonary venous return were harder to pick up, but also things like what type of practice. So university hospital settings were better at picking up these abnormalities compared to community sites. And in fact, that there was no, interestingly, no association with socioeconomic factors or demographic features in terms of predicting prenatal diagnosis of congenital heart lesions. Why does it matter whether we pick up a condition prenatally or postnatally? So this was an interesting study in the White Journal that looked at prenatal diagnosis of a congenital heart lesion. So it's a critical heart lesion, I should say, that was diagnosed. And normally these would be sort of streamlined into a tertiary care center delivery with cardiology and pediatrics and ICU admission, and then followed by surgery in a timely fashion. And with this, between birth and surgery, the mortality is about 1%. But when we miss the diagnosis, what happens is that typically the baby will go home from a normal newborn nursery. They will probably be readmitted in congestive heart failure or some other cardiac complication. They'll require ICU stay for stabilization and then eventually cardiac surgery. And in that process between birth and surgery, there is a significantly increased mortality. So we as sonographers, as imagers, as imaging specialists have a really important role here in improving outcomes and safety for our moms and infants. And of course, this applies not just to congenital heart disease, but all major malformations. There's also other important implications of our prenatal diagnosis in terms of litigation claims. So the NHS conducted a review of claims in maternity between 2000 and 2010, and antenatal investigations, predominantly obstetrical ultrasound, was actually a major source, or not an insignificant source, I should say, of claims and the value of those claims as well, when they looked at these maternity claims over a decade period. And what they found was when they reviewed these cases, that only about 60% of those cases actually had protocols in place. When they reviewed the images, about 70% of those images actually were related to human error in interpretation of those images. And about 50% of them actually had no images for review. So these are all significant issues that we all come across as well within our own regions and local areas in which we provide care. The other areas that came up for question were whether there was assistance available from senior colleagues, for opinions from senior sonographers or imaging specialists, how are standards being implemented, what was the training and auditing processes in these individual institutions. So again, all sort of quality improvement, quality assurance areas that are relevant to all of us. So we know it's important, but there are some unique challenges in obstetrical imaging. So as we're all aware of, there are technical challenges like body mass index, fetal movements, position, oligohydramnios, all of these things that make our scans very difficult at times. There is this very important dependency on our operators individually. As we know with ultrasound, we don't actually acquire images in a standardized way like a CT or MR, where we just get these slices and have to interpret them. We actually have to obtain those images and planes. And of course, our sonographers have variable training and experience. So that also impacts how our imaging quality is for our scans. And there are, of course, inconsistent standards. And I would say that the standards aren't necessarily inconsistent. It's the implementation of those standards that are inconsistent across regions and areas. And so this all leads to variable exam studies and quality. The other challenge is that, fortunately, I should say, congenital anomalies are actually rare. So we can actually do a pretty bad job most of the time and get away with it because anomalies are rare. So it's really hard for us to actually effectively track our performance. So this leads to the really important role of standardized curriculums, assessments for competency, and that also we share volume of normal and abnormal studies with our sonographers that are training and learning so that we really get experience in normal and abnormal studies. The other important role is the role of accreditation and performance measures that we can use to actually survey how we're performing on a regional and national level. So first, a few words on ultrasound education. So if we look at ISWAG, which is the International Society of Ultrasound Obstetrics and Gynae that you heard about earlier, this is really our main resource internationally for imaging and women's health. So they emphasize that if you're planning, if you're doing a training program or you're part of a training program, it's important to have some theoretical training, some practical knowledge as well, which means 100 hours of supervised scanning at least, that you can do 100 OB scans, 100 Gynae scans, that you have a logbook that's reviewed by a senior sonographer, that you work on your documenting and reporting skills, and that you're trained in that as well, and that there's some form of examination theory and practical. But there's not a lot about how to actually do this. And in fact, when you look at radiology residency, studies from radiology residency looking at ultrasound competency, less than 200 cases performance is actually insufficient to develop any kind of competency. And if you're more than 200 cases in any type of ultrasound imaging, you still probably aren't competent. So the number of scans and the hours of scanning are actually poor predictors of competency. They're important, but they're not the only piece. And we know this because we all have variations in our learning curves, we have differences in baseline knowledge, and so on. So it's not just about the numbers we scan, but also about how we scan and what we're taught and the curriculum that we learn in. So that sort of brought on this idea of developing a standardized curriculum that was led by Alfred Abu Hamed, as well as other international collaborators looking at a curriculum development for residency in obstetrics and gynecology. And this was really a first of its kind in recent times, really outlining in very specific detail about what competency should be performed and successful by the end of each year in a residency program in OBGYN over 4 years. And in fact, for each task, they have very clear criteria about what makes a pass score and what makes a fail score. And for each image, you have to submit actually 5 images for each task to meet criteria and pass that individual task. So really, this is the first time where you get very, very clear, vigorous kind of competency curriculum development in OBGYN imaging. And I think this can be applied to sonographers, this can be applied to radiology residents, really anybody, and you just sort of adjust the timelines accordingly, but really an important kind of work that was done in recent years to kind of standardize our training. So the training, the curriculum was important, but then it was still important to assess competency. So some of the authors from the original curriculum development actually led a Delphi consensus with radiologists and sonographers about assessing competency in ultrasound assessment. And really 7 important skills came to light when we're trying to assess competency in ultrasound, in that the individual is able to understand the indication, they have familiarity with the ultrasound equipment, they know how to optimize the image, they are systematic, they know how to interpret their images, and they document appropriately, and this leads to appropriate decision making. So these are all the important pieces that we do when we're training other individuals, but it's kind of more in a standardized way in terms of your assessment when you're looking at learners. And then this was actually validated by some of the same authors, again, in obstetrics and gynae imaging. And what they actually found was that this was just basically for obstetric biometry. So very basic assessment. They took some novices who had no skills in ultrasound, some trainees who were midway through their training, and some fetal medicine consultant who obviously had very much experience in the field of obstetrics imaging. And when they asked them to perform biometry and they graded them based on these competencies, you can see that they were very easily able to distinguish the novices from the very experienced fetal medicine sonographers or consultants. And this line here represents a pass rate. And then the intermediates, those in their training, were some were above and some were below that pass rate. So very much reflective of those in training, of some individuals meeting those kind of competencies and others not. But really important actually distinguishing those who are competent and really no experience or incompetent in ultrasound assessment. So some interesting tools and emerging data for assessing competency in OB imaging. So what about quality improvement in obstetrical ultrasound? Can we actually improve the quality once we've talked about education and curriculum development? So in France, in 3 major regional areas within France, they looked at their detection rate between 2006 and 2014. And in fact, it was quite stable. So about a 50% detection rate for major anomalies. And this detection rate was significantly higher in the presence of chromosomal abnormalities, so about 90%. But it did not change over that period of time. But what did change over that period of time was that there was, on average, at least 3 scans, so an increased number of scans in a pregnancy during that time period, so up to 3 scans. And in France, in fact, every scan is like an anatomical or a morphological assessment. So despite the increased number of scans, their detection rate was not improving. And so that really highlights, again, that we don't just need extra scans, we need high quality training programs to actually improve the efficacy of each examination that we perform. So what are these standards and how are they defined? So fortunately, we actually have a lot of standards available and they're all pretty consistent. We have the ISWA guidelines, AIUM, JOGC, and the Toward Optimized Practice here in Alberta, which I thought were fantastic, really kind of pulling all these together. So we have lots of guidelines to work with, thankfully. But then defining guidelines and implementing guidelines are a different story. So how do we implement this in a systematic way? So this is where checklists are really, really key. So checklists are key for us as sonographers so that we make sure that we are systematically assessing the fetus in the way that we're supposed to and not missing certain structures or tools. So it's a really key memory aid. And it's also very important for our reporting as well. So, when we're talking about the implementation of checklists, this was an important quality improvement assessment or initiative in Stanford. And what they in fact did was something very simple. They took the AIUM checklist, which is very resemblatory of the other guidelines. They put it on their machine. So they put that as a scan assist. And they basically looked at their scan completion rates before and after implementing this checklist. And what they found was that only 50% of scans were being completed before the checklist was implemented. Afterwards, with every cyclical or quarterly review, the percentage of scan completion was increasing in a statistically significant way. So just this simple tool of just checking it off as you go was very, very important to complete the scan. And this was actually irrespective of the amount of training the individual sonographer had, the years of training and whatnot. So all of us can benefit from this regardless of how experienced or inexperienced we are. Another important tool, again, in terms of ensuring that we're implementing our standards is reporting and appropriate follow-up. So again, when you use a checklist to do the scan, you also use a checklist to report so that we know and you know that the ones who are reading the scan and the ones who are doing the scan, that we've done what we need to do in terms of meeting our standards. And then most importantly, ensuring that we have appropriate follow-up. So when do we refer them to MFMs or echocardiography? What is the surveillance strategies if they're monochorionic twins? How do we communicate those results? And I was very impressed by the Toward Optimized Practice guidelines, because this is the first that I've come across where they've clearly very much identified that you need to try to complete all the scans by about 21 weeks so that we can really ensure that there is optimal assessment and opportunity for further assessment if there's an anomaly, further referrals and so on. So we can really kind of offer the individual patient and couple all options that are available in a timely fashion. So I think that's really, really key. And I think a lot of the guidelines are actually lacking this piece in terms of the time sensitivity of referrals to a tertiary care center where you have additional imaging support and diagnostic services. So the final piece about implementing standards, so to make sure, again, that we're doing our jobs right, is image audits. So image audits are a lot of work. They take a lot of time, but they're really important. So in Netherlands, actually, they review periodically. All of the sonographers have a periodic audit of all of their images in the country throughout every, sort of in a cyclical way. And so this was a study just from the Southwest region of the Netherlands, where they took their sonographers and they randomly selected their cases, and they had those audited over a period of time. And what they found was that about 15% of their sonographers in that region were actually not meeting national guidelines. And the score on their audits, so the scores were actually higher if they had done more scans per year, or if there was more sonographers per site. So these are probably just surrogates for more experience or higher volume settings, of course, and we know that these things make a difference. And this was also demonstrated in this study as well. What they also found was that for the individuals that did not meet the standards initially, they provided remediation by providing hands-on training, a bit more educational support. And at the second audit, all of them actually met standards. So we have an opportunity to actually improve performance by, first of all, looking and seeing how we're doing, and then intervening and making our performance, or working towards improving our performance. So audits make a difference for sure in terms of our quality of imaging. So just a few sort of, sort of a little bit about my own experience working with international training programs through ISWAG Outreach. And I think it highlights a lot of the points that I've sort of just commented on. So I had the opportunity to work with ISWAG Outreach as a volunteer educational trainer in Oman between 2017 and 2019. And for those of you who are not familiar, International Society of Ultrasound and Obstetrics and Gynecology has an outreach program. And really their mission is to bring comprehensive and a sustainable OBGYN ultrasound education globally by training competent providers locally. And really, of course, this is to ensure that every woman can access high quality ultrasound services with the aim of impacting health outcomes. So very much in line with the millennial goals for improving maternal health outcomes. This is a bit of a dated map, but these are all the programs that were initiated by ISWAG Outreach, and there's probably more now. We were in Oman during that period of time. As I mentioned, we had trainers from the UK, Estonia, Netherlands, India. So we were a pretty diverse bunch. And these are all our trainees from Oman in this picture here as well. So all of these outreach programs have a similar curriculum, and the first phase involves international trainers who go to these different areas which have recognized the need for OB imaging, or women's imaging, I should say. And we basically spend the first week there training basic ultrasound skills in fetal biometry, knobology, and basic gynecologic assessment. The trainees are actually selected by the Ministry of Health in most of these sites, representing individuals from various parts of the country that are important to providing service, and particularly the remote areas as well. So we don't actually select the trainees, but these are selected by the ministry to ensure that we have appropriate service across the country. So that's the first week. And then the second week, we go back about 6 to 8 months later. We teach a little bit more about the anatomical survey, a little bit more about first trimester complications and gynecologic pathology. And then finally, the last week is really we go in and kind of emphasize the importance of major maternal morbidity, mortality type diagnoses, understanding the importance of referrals. So really the key things that need to be referred out, and really recognizing those emergency type situations. And in between all these weeks, which is basically occurring over about a 2-year period, the individual trainees are practicing their skills. They're doing that either locally, or they're coming back to the university hospitals to get some hands-on experience. We're constantly communicating with our small group of trainees virtually with WhatsApp and things like that, to ensure that we're actually that we're making progress and providing feedback. And then ideally, after that, that first phase, we're able to get all of these sonographers to a minimal sort of competency. And then from there, we can select about 5 to 6 trainers that we think can actually be teachers locally to train in the second phase, which is led locally, but supported by ISWAG. So it's a really important kind of process in terms of ensuring sustainability within the local environment that we're working in. So we did in fact just that. And this is just an example of our curriculum that was very detailed. And every week we'd have a different curriculum. At the start of each week and at the end of each week, all of our trainees had to do a written theoretical assessment to assess their knowledge. Every day we spent half the day scanning on volunteer patients in small groups. So everybody had hands-on training time. And at the end of that week, they would get a practical assessment where they would get a skill that they'd have to scan, and we'd watch and give them feedback, and they would have to document document their findings as well. What we also introduced to the outreach program was the logbook assessment, as I showed in the Netherlands. Our lead educational sonographer was the senior author on that paper, and she leads the audits in the Netherlands. So we did exactly that same process for our trainees. And it was very, very helpful to recognize who was sort of at the competency level, who needed a bit more training in certain areas. So really, really helped us identify educational needs as well. I think the big key, lessons that we learned while we were there was that it was really important to adapt to the local context. And this is important no matter where you're doing outreach, whether it's in Northern Canada or Northern Ontario or whatever, or in Oman, that there are always cultural and factors. And in our situation, there was, different cultural and religious factors. All of our women's health providers were females, actually, for cultural reasons. That was, was just accepted that it would always be a woman provider. And that was part of the challenge. A lot of these women weren't able to get additional training in imaging, for instance. They had their own home responsibilities and a lot of responsibilities in women's health that they had been given to them, but didn't have that adequate training like ultrasound imaging. So the ministry was really, really instrumental in helping getting these women out from different parts of the country, bringing them in every time we came from that week session, and also in between to ensure that they were being trained at the university hospitals. The other important piece we recognize is that most of these women had very little antenatal care. They just didn't understand the importance of it. It was just not, the knowledge was just not there in terms of recognizing severe maternal morbidity and mortality risks with, say, things like placenta previa, first trimester complications like ectopic pregnancy. So we have to do a lot of education around the importance of ultrasound care. And so it was just a lot of education, I would say, and a lot of recognizing different obstacles that were there specifically in this context. The other thing we noticed was that many of the centers weren't actually, standardizing or actually plotting growth. So plotting growth was a very foreign concept. And so we introduced this idea, this importance of serial growth assessments. And we actually implemented the intergrowth growth curve use or growth chart use across the country. And we had our sponsors from GE actually who were providing the machines. And so they put them on all of their machines as well. And the ministry also helped circulate that as well. And we chose intergrowth because Omani women were actually part of that initial study as well. So just kind of simpler things that you wouldn't really think of, but we recognize were kind of important issues. The other important key issue was transvaginal imaging. There was a lot of obstacles to actually performing this type of imaging, a lot of resistance, just not lack of comfort or lack of understanding of its importance. And so therefore our trainees didn't actually get a lot of experience in transvaginal imaging. And we had a simulator that was provided. So that was really important, allowing them to train and understand gynecologic pathology without necessarily that hands-on kind of experience. So just a few final words on some of the lessons that we learned, I think, while we were there, was that it was really, really critical to have support of academic institutions, local government, and industry to actually help make this program sustainable. And we were very fortunate to have that. We also understood that when we weren't there, it was really important to provide virtual mentorship, which we continue to do. And we did during that time period as well, through simple things like WhatsApp group image sharing. We also did Zoom calls after the phase 1 was completed, and Zoom program training programs. And Trice was also a very interesting ultrasound cloud type tool where we could share anonymized images and provide consultation and advice and support. So lots of technology there involved that was really, really helpful. And the final piece that was particularly rewarding was that we were able to select those trainers locally who actually launched the second phase just recently, training their own next set of sonographers that was really led locally and just supported by ISWAG. So that was really important. And it's really, really key to ensure sustainability of these kinds of programs. What we left with, when we left, there was always this question and discussion about how could we assure quality assurance and performance. And I think these are the same issues here in our own institutions as well. So I'll just spend the last few words talking about quality assurance and obstetrical ultrasound. And so accreditation is a really important piece of that. And I think regular accreditation really plays an important role in ensuring that we're meeting our standards. So unfortunately, in most of our, in most settings, it's actually a voluntary process. So for instance, AIUM provides a voluntary accreditation where they check credentialing, CMEs, and they review cases from these different institutions. And when the study was conducted in the US looking at accreditation, only about 40% of US facilities were actually accredited. And among those seeking accreditation, 40% were actually operating below guidelines or national guidelines. But what they actually showed was that with the accreditation process and re-accreditation, you could actually improve the standard of imaging standards by when they reviewed the images every cycle. They saw that it was getting better objectively, and that those that didn't initially weren't accredited, they were actually re-accredited with the second cycle. So clearly this was impacting performance. I think that Alberta is definitely ahead of us in many other provinces by ensuring a very strict accreditation process where there is regular renewal processes as well. And I really think that this is what we need across the country in a more uniform kind of fashion as well. As another example in terms of quality assurance, so, for instance, the nuchal translucency assessments, we have very clear competencies and certifications from the Fetal Medicine Foundation. This is what we call a standardized measurement. And we know that the nuchal translucency measurement, the thicker it is, the higher the risk of aneuploidy, congenital malformations, pregnancy loss. So it correlates with a lot of poor obstetrical outcomes depending on the severity of the nuchal translucency thickening. But when we looked at this in Ontario, so actually the Prenatal Screening Ontario program looked at this, what they found was that about 75% of sonographers in Ontario, and this is in 2014, were systematically under measuring the nuchal translucency. So we were actually underestimating the risk of all of these complications due to quality assurance issues in the NT measurement. And what the labs here were doing was that they were actually creating sonographer-specific curves, and they were generating coefficients to actually adjust the sonographer's NT if they were out of range. So if they were performing like this, they would basically have a coefficient to correct their NT so that it was more reliable. And this is a huge issue, obviously, because the NT is less reliable. This leads to inconsistent screening results, and we're not actually addressing the problem, which is the NT measurement. So from there, Prenatal Screening Ontario developed an NTQA initiative, and this was really to develop a sustainable and effective NTQA program in Ontario to boost and maintain our performance, and also to develop a user-friendly platform where sonographers can actually access their curve. They can see if the parameters are within range, and if they're doing their job the way that they should. And if they're green and yellow, they're green, they're okay, they're doing well. Yellow, maybe some issues that may need to be corrected. But red was clearly an area of suboptimal performance. And at this point, if this was the case, the license would be suspended. There would be review of the images and remediation, and then a second audit process to ensure that there was appropriate improvement in the performance. So really, really an important quality assurance initiative here that I think is something that we're all very proud of in recent years. The final sort of words about performance indicators, a little bit more general. So this is from the European Surveillance of Congenital Anomalies. So this is all openly and easily available, where they actually put their congenital anomaly detection rates up for Europe and for the major congenital defects. And they also talk about what percentage of them are prenatally detected. And they also provide local and regional data, perinatal outcomes in terms of in utero demises, termination of pregnancies, neonatal demises, live-born. So all of that information is easily accessible. And this is important because it'll show the impact of prenatal screening programs. We can compare outcomes between different regions. What can we do better? What are we doing worse in certain areas, and so on. What are we doing in Canada? It's not quite as detailed, unfortunately. And what we're actually just doing is we're just demonstrating what the congenital, for instance, here, this is congenital heart defects. So what the detection, what the incidence of these anomalies are over time. But it doesn't really talk about whether these are prenatally or postnatally detected. What are the outcomes? So that data is just lacking, and it really makes it difficult for us to actually, benchmark where we're at and where we should be when we don't have that data. And when you have that data, again, this is great work from the Netherlands. This allows you to conduct really effective national surveillance programs. So this was just looking at congenital heart disease before and after introduction of routine screening. And of course, what they found was that they had significantly increased their congenital heart disease detection rate after implementation of screening. But this allows them to monitor how they're doing and watch over time. And if you just don't have that data, you just can't do that. And really, you cannot focus on an area for intervention and improvement. So again, things that we should kind of be working hopefully towards nationally and provincially as well. So just to summarize, we touched a little bit on education, curriculum development, competency assessment, and we talked as well about quality improvement and quality assurance in obstetrical ultrasound. How do we, particularly implement standards effectively, the role of checklists, audits, reporting, the role of accreditation, as well as national or regional surveillance programs, which are really important in terms of demonstrating how we're doing and how we can do better. And I think our Canadian SOGC and our Canadian Associated Radiologists and our local provincial organizational bodies really have an important role in kind of moving towards so that we can actually reach the kind of standards in many other parts of the world in terms of reporting data and performance evaluations. So I will stop there for this part of my talk. And from what I understand, this questioning will all be at the end.